Hi, everyone. I'm David Williams, president of strategy consulting firm Health Business Group and host of the HealthBiz podcast, a weekly show where I interview top healthcare entrepreneurs about their lives and careers. If you like this episode, make sure to hit that like button and to subscribe. My guest today is Jean Drouin, founder and CEO of Clarify Health Solutions. Jean, welcome to the HealthBiz podcast.
David, pleasure to join you. Thank you for the invitation.
Now, listen, Clarify Health is super impressive. Everybody tells me how great it is. I assume you'll tell me the same. But I want to hear a little bit about how you got there, and maybe just starting way back with your background, your upbringing. You know, what was your childhood like? Any childhood influences that have stuck with you to this day?
Sure. So, as you can probably guess from the French-sounding name, I didn't grow up in the U.S. I grew up in Montreal and Quebec City in Canada, and learned English actually when my family moved to Ottawa when I was 8 years old. I come from a family of physicians. So my dad's an immunologist. My grandfather was a cardiologist who brought back the first X-ray machine to Quebec City from Paris on the last boat before World War II. And my great-grandfather was a GP working in the logging camps in Quebec. So I suppose I've had dealt with a lot of healthcare growing up. And actually, interestingly, initially I wasn't thinking about going into healthcare. I had it in my mind that I would go to law school and into politics in Canada. But eventually, apparently, the gravitational pull of being in healthcare and helping, in society just came a little too great. I came at it in a roundabout way. I was working for the Mandela government in South Africa just after college, helping figure out how to bring electricity to the townships, and realized, you know what? The industry I'm really passionate about ultimately is healthcare, and I'm going to go to medical school, which I did. When I went, I was 50-50 as to whether I practice. 3 months into med school, about halfway through the anatomy class, I decided I wasn't going to practice. That said, I was going to finish because it was such an amazing experience. And ultimately, I had this inkling that it would really help out and that I would end up in some role somehow helping to work on fixing the health system. Now, what happened is I ended up back at McKinsey thinking I'd do 2 years and get my school loans paid off. And then, sometimes in life you have to go with serendipity. And I got asked on what I thought was going to be my last project to go over to London to help set up the UK's new hospital regulator, which turned out to be code for Tony Blair really wants to reform the National Health Service and bring in more value-based payment models. And 3 months turned into 8 years in the UK.
No, that's a pretty good story. So that, as childhood influences go, that's a pretty good roundabout, trip from Quebec to South Africa, back somewhere, and then over to London, and got stuck. But you didn't get stuck there forever. But it sounds like as you said, the gravitational pull of healthcare brought you back one way or the other. I think a lot of the people I talk to on the podcast who are in healthcare, their parents were in healthcare, physicians or whatever. One guy's actually named Michael Doctor. And I asked him, how did you decide to become a doctor? And he took the question seriously. His parents were doctors. He helped people when he was a kid. And then, he became a doctor. It's like, you already were a doctor. You didn't even have to go to medical school, for that. But that sounds, that sounds pretty good.
I have a funny story for you. Back when I was debating whether to go to medical school or not, the head of the Canadian office for McKinsey, this guy, Ron Farmer, was a bit of a legend. And he said, wait a second, a bit like what you just said, I can go buy you a medical degree in Mexico. If what you want is the title, we can deliver it. And what I'll never forget is, and then they had somebody else come in and say, are you really sure you want to go? Because in life, you want to grow at this rate. And, in medical school, it's a lot of memorization and whatnot. And but the funny thing is it's the humanity of the experience and going through each of the rotations and actually seeing with your own eyes how the healthcare system works. And because I'd been at McKinsey for a couple of years before going to medical school, every time I walked into a situation, I was like, this is unbelievable how screwed up this is from a production system point of view. So I think I went through medical school with a very different lens on how I was experiencing it, given the background that I had had, working in consulting for a few years before that.
So what was the experience like at McKinsey? You were there for quite a while, and as I saw it, some of the time on the client service side, but it looks like you're also involved in some other initiatives there as well.
Yeah, I would say it turned out for me to be an incredibly varied experience where I had an unusual chance to be what you might call an intrapreneur. So an entrepreneur within a bigger company. It turned out that when I got to London and we started working with the National Health Service, McKinsey hadn't done a ton of government work at that point, certainly in healthcare. And, we ended up with quite a broad relationship with the National Health Service. And one of the things that happened was the UK government centralized the administration of the National Health Service into 9 regions. And so London was aggregated into one region. And they appointed a force of nature CEO, this woman, Dame Ruth Carnell, who walked in one day and she said, hey, listen, I will partner with McKinsey in a very deep way. But here's the thing. You have to come and work for me full time as the head of strategy and the budget to help set this up. And McKinsey had never loaned out a partner full time and said, well, you can't do this. And I said, well, actually, look, the world has changed. I am going to do this. And so I ended up having this experience when I was 32 or 33. Effectively, Ruth walks in and says, hey, this is the way it's going to work. Here's my pen. The CEOs of the hospitals are going to come. If there's not going to be a political issue, then sign off on their business plans, new MRI machine, new wing, whatnot. And if there is going to be an issue, let me know because that's what I have to manage. And that experience was incredibly formative because I learned very quickly, it doesn't matter how smart you are. It doesn't matter how great the policies you think you're going to put in place are. The fundamental issue, or one of the fundamental issues with looking at a health system is, sure, the health economists will tell you 20% of 25% of spend is wasted. The issue is that waste isn't hiding out in plain sight in 2 or 3 places and you change 2 or 3 laws and bang, you're done. It's stuck in every little micro decision that's made in every patient journey. And when you stack up every patient journey, it adds up to total spend. And some of that spend just isn't that helpful. And so I came away from that experience with a very clear view that what's missing in healthcare is a real-time patient journey optimization system and the payment models to pay based on that. The only thing is in 2008, the data didn't exist to even dream of putting that together at the time. And I believe, by the way, one of the big reasons why value-based payment models haven't taken off is because fundamentally we've been trying to impose structures where we don't have good enough insights to be fair about the bonuses and the penalties that we're handing out.
Fair enough. I think it's some great insights. One of the things that I think holds us back in the U.S. is that we don't have a perspective on healthcare systems in other parts of the world. We tend to sort of, look down on them, and I'll make certain assumptions about, how they work. And I think the U.K. is a good example. So, you talk about, for example, hear people talk about waiting lists in the UK. Hear people say that and say, that you have to wait for care. But what I found in looking, on NHS websites, you can actually look and see what those waiting lists are and what the time is for different services in different regions. Try to get the same information here in the US and you can't do it. The best you can find is a journal article of somebody calling around dermatology offices with the best example of an emergency they could have, a changing mole, and ask for an appointment. And you see how far out you went. And this was in Boston, I think it was. I'm remembering this journal article. So there isn't anything even systematic about it. So the on the one hand, it's interesting about we tend to overlook the kind of the insights and the accountability that are in some of the other systems. And then the other thing I hadn't appreciated is that there is an appetite in some of these systems, in particular in the UK, even for like US style management and insights. So some of the people that I meet, like from the Institute for Healthcare Improvement and stuff like that, or even ICER, here, some of their best, some of the most receptive audiences they have are actually somewhere else. So I'm just guessing that some of those experiences have helped inform what you've done with Clarify.
Well, they have. I mean, I think one of the biggest learnings for me was however it is you incentivize and pay for healthcare has both positive and then unintended consequences. So fee for service is quite immediate, right, in its reward and encourages activity. And so as a result of it, for certain things, if you have the luxury of access in the US, you do get care very quickly, and it tends to be very good care. You know, a system like England's is based on budgets and people are salaried. And so you end up, you know, with, if you have basic needs or chronic disease, you're taken care of very well. As you say, there are wait lists and there is rationing for things like hip replacements. So it's almost like you have to choose your benefits and your poison or disincentives, if
Yeah.
you will. And the dream here is to create a system and a set of insights that helps both solitudes, if you will, the fee-for-service one and the budget-based ones, to be able to deliver far more effective and efficient healthcare.
Yeah. Well, good. Well, the good news is that there's there's a long career to be made doing that. I was happy when you talked about being 32 or 33, which I was some time ago, and thinking at the time where there was like the telecom bust. I said, well, I'm glad I'm working in healthcare because I'll have something to do. And then, not that I'm going to retire anytime soon, but as I look ahead and I say, are things still going to be solved by the time I'm retired? Or are we going to be still back at square one? And well, I think we've made progress in some areas. I think it's an open question, and maybe Clarify can help that. So you had a real clear reason to go and do this unusual thing in the UK as a McKinsey partner, but you're not doing that anymore. So why did you found Clarify? What was the unmet need? What was the impetus to do it?
Sure. So deep down, I had this thing where the people I most respected were my medical school classmates who had the guts, in my view, to go and start companies. Some of them were in biotech, some of them were in healthcare services, and as you know, I mentioned, I had this idea of, okay, healthcare is ultimately a giant production optimization problem. And late 2014, I had a bit of an aha moment. I said, wait a sec. Niall Brennan and Patrick Conway and their friends at Medicare are about to make all of their data available. And cloud computing is now becoming a real thing and enabling things like machine learning and AI. Now, I think of machine learning and AI as the application of known statistical method with lots of computing power that allows us to now do better analytics. Okay, let's simplify it. And then that was the second thing. The third thing, which I got horribly wrong, was Hillary's going to get elected and Patrick and their friends at Medicare are going to make bundled payments and other value-based payment models mandatory.
Yeah.
But
yeah, Hillary went in another direction, and so did Patrick for a while, but that's another story.
Correct. So that was enough, though, to convince me to take the jump. And I had the amazing fortune of being introduced by a mutual friend to my co-founder, Todd Gutula. Todd had been the chief technology officer at a company called Advent Software in the financial technology industry. Advent had built the cloud platforms used by Goldman, JP Morgan, and others to take all of the world's trading information across equities, bonds, et cetera, and in real time mark the books back to market. And where it got interesting when Todd and I met was Todd said, yeah, we're applying machine learning and AI to forecast the value of derivatives. And I said, wait a second, farmer hedges against the weather hasn't happened yet? And he said, yeah. And I said, well, look, in my world, it's a patient comes in with a set of clinical and social characteristics and their journey hasn't happened yet. And so effectively what Clarify is the application of very powerful financial services analytics technology married together with one of the largest ever patient level data sets. We now have data on over 300 million Americans, and we see both what's gone on clinically and how they behave, both in terms of the types of things that go into credit scores, but also the food that people buy, credit card purchasing history, et cetera. And we are able to use that data in a de-identified way to be able to do these kinds of things. So one is better understand who are the best clinicians out there. Now, what is it that clinicians say anytime you compare them? They say, whoa, my patients are different.
Yeah.
They're always more complex, right? In fact, we should set up an award where the first clinician that says my patients are simpler, they win the award. So what we did is we said, we're going to solve this problem, and which is obviously a problem of trust. What's the industry that has best solved the problem of assessing differential human performance? It's baseball. So we said, fine, we're going to apply baseball Moneyball or wins above replacement analytics to healthcare.
Yeah.
Now, why are we able to do that now? Because we have a large enough data set. The next rejoinder was, well, it's not EMR data. I said, sure, but it's every other piece of data in the country. And by the way, what's a claim? A claim is what comes out of an EMR. I mean, the purpose of an EMR is to generate claims. So we have solved that problem of assessing physician and hospital performance in a fairer way, and we combine it with an ability to forecast how patients are likely to trend through their journeys based on their needs. As a result of that, we've been able effectively to create the first ever Bloomberg terminal for healthcare, where we enable lots of business problems faced by hospitals, payers, and life sciences companies to be solved by rapidly accessing insights on what are the best referrals, who are the best doctors, how can people improve, how do you more quickly find patients for clinical trials. Those are the questions that are business applications off of our platform help hospitals, payers, life science companies to solve. So that's how we started. Now, where we're going ultimately is to be the platform that enables value-based payment models to be trusted, automated, and far easier to deploy.
So did you have that same kind of vision when you got started? It sounds fairly, linear and pretty clear of an arc. Did you know that's where you're going?
Well, we had a sense that that's where it could go. When you start, you have to be incredibly focused and incredibly humble. Healthcare is quite hard after all. And so initially we said, hey, we're going to provide the best possible patient journey analytics for anybody that's in bundled payment programs. And based on that, we'll expand. And truth be told, our first customers, John Muir Health in the Bay Area and Hoag in Orange County, ended up quite quickly using the insights we provided, being some of the best at generating value, i.e. surplus, from bundled payment programs. Thankfully for us, we got far enough along with that we were able to convince KKR in 2018 to back our Series B, just at the time that Tom Price basically killed all bundled payment. So then we had
he just snuffed it briefly, right? It was more like one of those birthday candles, you blow it out and it looks like it's out for a while and then it springs back. Although I'm not sure it sprung back of its own accord.
Correct. And but we were able to move from just 40 million lives of Medicare data to 300 million plus lives. And in healthcare, what we say is you have to be a pragmatic idealist. So we said, fine, we're going to provide analytics for the problems that people have today. So how do hospitals make money? They make money by optimizing referrals and bringing in more referrals and the right patients, and then providing the right care. We'll provide you analytics for that. How does a payer make money? Well, they pick the best docs to put in their networks in geographic areas. They help them to improve, and they want to understand their risk. And so we said, we'll provide you analytics to do that. And that's what effectively took us to where we are today. And what's happening is it's interesting. The commercial payers are now wanting to accelerate the adoption of value-based payment models. And their issue is that they have multiple models in contract to manage across multiple lines of business, Medicare, Medicaid, et cetera. And they need a way to, instead of managing this on spreadsheets, to digitally load in the contract rules and have a trusted third party that says, hey, here's the baseline performance before, here's the baseline after, based on the rules, here's who gets what, and ideally eliminate this notion of two revenue cycle armies fighting over each other, which doesn't do anything for patient value ultimately.
Right. So, you talked about being humble before, which is great. But now let's say you've achieved some degree of success, and we're just talking about, value-based care. One of the reasons you said it wasn't working before is you don't really have a way to measure it and know if you're, you can put rewards and punishments, but are you really doing the right thing? But in principle, people would like to have value-based care. It's good for the patient. It's good presumably for the payer and good for the providers that are doing a good job, and you don't have all this sort of friction of the administrative side. To what extent does Clarify actually enable that to occur, stepping out of the kind of the humble side? I mean, is it just, hey, now you're the missing piece and now it can happen?
Okay. Great question. There are various payers out there that have RFPs or competitive processes ongoing, wanting to bring in technology to automate some of the challenges that, as I've talked about. And there are vendors that go in and they say, hey, here's the technology will solve it. Fundamentally, though, at the end of the day, this is a problem that can be helped to be solved by technology, but the root of the issue is one of behavior change on the ground in terms of how decisions are made today. And one of the fundamental issues right there is one of trust, right? The doctors are saying, wait a sec, you want me to move from what I understand, which is fee-for-service, to some new way of paying for me. You better be able to convince me that I'm going to be the same or better off on the other side with less administrative hassle. Otherwise, it's no use for me. So what I always say is the technology can help, and you have to be willing to collaborate with the docs and offer them payment models that they're going to want. I do believe, though, that what we are doing, there's one critical difference that will help to enable in a way that hasn't been enabled before. So the bundles, ACOs, et cetera, all rely on a retrospective look back that says, how did you do? And based on that, there might be a pot of gold for you on the other end. What if, though, you had good enough analytics to say, David just came in, David needs a hip replacement, David's otherwise healthy, David's hip does not need to get done in an expensive in-hospital setting, could be done in an ambulatory surgery center. We all know that that's cheaper and lower length of stay, less risk of infection, et cetera. Because we know it's a good thing, David's not going to have to wait a year for a bonus. At the end of the week, there's a bonus in his bank account. And what if you could replicate that across a multiplicity of use cases, a drug substitution, choosing the right imaging modality, not ordering unnecessary tests, et cetera. And so effectively what you have is this notion that there are actionable appropriateness metrics across various specialties that you can measure. And as people do these things, you can reward them immediately. That's why we bought Embedded Healthcare, Zeke Emanuel's company, a few months ago, because Zeke's vision for that, we firmly believe, is what will ultimately unlock value-based care. But the irony is it's taking fee-for-service and making fee-for-service valuable. So, look, I would say this. The way to value-based care is actually by making fee-for-service more noble and valuable.
That's great. See, it gives some pretty good answers to my questions here. It made me forget that when you're talking about Niall Brennan, one of the reasons that you've been successful enough, you got the resources. Now you went and hired him, even though he's he's a podcast guest too. He beat you to it. He's been on the HealthBiz podcast before, and actually, I spoke to Zeke Emanuel recently on another podcast that I co-host, and he is describing himself as like the lonely guy. He's the only one that seems to care about long COVID. He's wearing a mask, and he's like, he's just in his own. He seemed to be concerned if he was still attached to society, but I'm glad that he's embedded in it enough. I guess he's given that up now as well, that you've taken it over.
Well, and we're working very closely, and he's been incredibly inspiring, as has Niall.
Yeah.
We're incredibly, fortunate to and to have him on the path as well, helping us out. And now, look, it's healthcare, right? A great innovation takes 17 years, right?
That's still, are we still using that number?
It certainly feels like a trying to scale company, let me tell you that.
I think it's like that. I think they use the 17 number partly because it was empirically derived, and partly I think that's like the cycle of the locust. So, so it's like when the locust comes back out.
I haven't heard that one, but it's good. Yeah.
So on the value-based care side, I have a question, may not be completely pertinent to clarify, but one of the issues with having all these different payers is not just getting the data, but it's also the incentives are different for the same provider depending on what patient they're seeing and in what context. So as maybe a stark example, if I'm a hospital, the way I can make a lot of money in fee-for-service is by having somebody a patient on a specialty drug that's administered in the hospital. So if somebody has sick, let's say with cancer, if they have one type of insurance or one type of a contract, it's going to be better to have them go home and have an oral med. And another one, it's going to be better for them to be at the hospital and be infused. And it's the same oncologist. So can somebody actually work in that environment? Or do we have to get does it have to be 80% value-based care before it works at all? Or, can these things coexist?
So a few years ago, I would have said to you, it needs to go to 80%, otherwise it's not going to work. I now have more faith that we can get to the degree of personalization that we need to be able to be discerning enough to operate in different modes. Now, there's an ethical question around, should we even have that? Let's just put that one to the side.
Yeah, one question at a time, right? Yeah.
Yeah, exactly. It is now possible. You know how when you and I have to download a widget on our computer like Zoom and it takes a few minutes and then presto, you got the capability. There is now technology where you can download a widget onto any EMR. And that widget looks and feels to you as if it's from that EMR and can provide you instantaneous decision support. So you can envision a world where you instantaneously confirm that this is the member, that this is the coverage of the member, and for the incentive of the practitioner seeing that member is to prioritize ABC.
Yeah.
That is not the world of science fiction so much anymore. Now, deploying that at scale, I would give a 3 to 5 year time frame. Yeah. It's possible though, and as a result of being able to entertain something like that, you see how it could dramatically decrease the activation energy to moving to value-based models. Now, if you are a brick and mortar hospital that has just spent $1 billion building a facility that has a 30-year depreciation schedule, it is going to be tough no matter what, because care is moving to the home. Care is moving to CVS, Amazon, and Walmart. Care is moving, to telemedicine. And so your ability to fill the box is going to be, monetize the box or defray the cost of the box is going to be challenged moving forward. And intriguingly, I look at the hospital sector and I say, wow, the ones who've been moving aggressively, for example, to partner with or buy ASCs, partner with or buy home care capabilities, feel to me like they recognize this and are setting themselves up to be able to be successful no matter what the payment models are.
Another interesting thing has happened since you mentioned, Tom Price, who was probably against value-based care, just as a physician preferred the, fee-for-service kind of revenue maximization. But one thing that's been different, under the Biden administration compared to under his predecessor was trying to make value-based care also tied in with increased equity, which was never a concept before. Do you think those two things go together? Is that a good way to achieve, greater equity in healthcare, to have more value-based care?
I think that's all down to the way you write a contract. And one could absolutely, well, it's going to be hard to get to, and this is, Jean, the individual talking,
Yeah.
right? Jean, the
I just
CEO.
I already asked the fair questions. Now we're in the section where I ask the unfair questions.
Yeah, no, exactly. Um, System-wide equity, which is, if you're Biden, presumably what you're speaking of,
Yeah.
right? It's going to be hard to deliver that in a world where some people have gold-plated plans, sponsored by well-to-do employers. Some have not so great plans by employers who are more challenged, and you have folks who don't even have access. If one's talking about equity at that level, I don't think that has anything to do with value-based care. That has to do with how we choose to pay for health insurance broad writ across the
Yeah.
country. Okay, now, is it possible that you could put into contracts, or if you will, standardize across contracts so that there's a basic package of care and services that is delivered to everyone across the US? Sure, one could entertain that in contract design. That is where I believe the federal government can have an incredibly important role, which is to say, in order to get federal funds for certain things, or, Medicare, any plan needs to be able to provide, certain types of care. I think that's how you get to equity. And the value piece of it is then, in delivering that basic package, are you doing so effectively and efficiently? So I suppose, my answer is they're related, but they're not the same.
Fair enough. Well, now I'm going to ask you a question where you can't get yourself into trouble, so don't worry. So I saw there's an announcement that you made with Datavant, and I saw this term there, so I want to hear about what's involved in that. You also use the term first-party data. So I've kind of heard of third party. What's first party? And then is there a second party?
So first party data tends to mean that where you're getting it from is who generated it.
Okay.
So if a pharma company is doing a trial and generating data through the trial, and you're directly helping the pharma company, they're dealing with their own first party data, right? Third party means that, you go to Datavant and you buy, somebody else's data. It's a good question. I don't know who the second party is.
There may not be one. It's one of those things you never really think about it until you say third party. That makes sense. But then when you say first party, then wait a minute. Somebody's got to be in there. It's like I know you're not from here, but there's like Division 1 in college and there's Division 3. There actually is a Division 2, but it's pretty small and it's been getting smaller. So maybe it's related to that. We'll have to have a follow-up podcast on that question.
Exactly.
Great. So I want to ask you about just turning it now back to the personal side and ask about reading. And in fact, if you have time to read any books and if there's anything you recommend or in fact, anything you recommend we avoid.
So in fact, I love reading. I think it's an important pleasure that if you love doing, it's important to do it. Now, I tend to do it in the morning when I'm on my exercise bike. And I love reading biographies of either great political leaders or scientists. And the one I'm reading right now is Einstein's biography and by Isaacson. And what I found interesting, I'm almost through it now, is I was like, wow, he was actually an ultimate physics entrepreneur. When he came out with his theory of relativity, it was incredibly countercultural in the physics world. And talk about being stubborn and sticking up for yourself. Now, maybe there's also a lesson. He spent the last 30 years of his career trying to find a grand unification theory, and turns out that's not where one needed to go with subatomic particles. And but yeah, look, I find it really, really interesting to hear things or lessons from other places and then try to apply them to the situations we're in. So yeah, anybody who's intrigued by Einstein as a personality, it's a wonderful book, and obviously Isaacson's a great biographer. So
sounds like a good combination. Will you give me one to avoid, or
one to avoid?
You don't have to do that. Do you put down books if you don't like them?
Yeah, absolutely. You know, it's funny. In college, we had a great Latin American history professor, and this is an interesting lesson. About 5 weeks in, he comes into the class, and it was so memorable. I still remember the room and where we were. He says, okay, you're all probably drowning in the amount of reading I've assigned. And yeah, people are, yeah. And then he says, well, everybody raise your hands if you've read everything. And, you know, a few people raise their hands. And he says, well, listen, I'm thrilled that you have, but I feel really, really sorry for you, because he says, do you think I would ever assign you a bad book? No. And he says, okay, well, what does a good book look like?
Yeah.
A good book has a great introduction, a great conclusion, and a set of chapters who also have great introductions and great conclusions. So he says, here's my advice to you in the future. Read the intro, read the conclusion, decide if you're now going to read the chapters, and read the chapters in the same way. And then,
yeah.
So I won't claim to read in that way necessarily, but it is a great way if you're not sure about a book, right? Is go to the end. Now, obviously, if it's nonfiction,
right,
and come back. If it's fiction, then you have to trust that the story is going to pick up.
Makes me wonder how this guy eats his dinner, but it's an interesting concept. Well, we'll leave it there. So, Jean Drouin, founder and CEO of Clarify Health Solutions, thank you so much for joining me today on the HealthBiz podcast.
Thank you, David. Wonderful. I had a great time.
You've been listening to the HealthBiz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.